Hello and welcome to Psychedelic Chat. My name is Wendy Marusich. I'm one of the co-founders of Open Nurses, the organization of psychedelic and entheogenic nurses. Tonight, I have the honor of interviewing Amanda Vogel. She is a PMHNP who was born and raised in New York City. She worked for 17 years in the trenches of acute inpatient and emergency psychiatry at New York Presbyterian Hospital and Weill Cornell Medical Center. In early 2019, she was asked by the unit director to initiate, design, and operate a new ketamine infusion service for acutely depressed and suicidal psychiatric patients. Coincidentally, when this project was presented to her, she had just recently begun her own personal foray into therapeutic, non-ordinary states of consciousness. Inspired by her own experiences and by the potential of ketamine to catalyze deep healing, she became motivated to make this medicine her primary focus, and so left her hospital job in January 2024. She is currently employed as the ketamine provider and clinical director of the Stella Center in New York City. So my pleasure to welcome Amanda. And if you're tuning in live, please let us know where you're watching from. Add to the comments. Hey, Amanda.
Hi.
Hey, great to see you.
I want to say thank you for having me here. I love Open Nurses, and I've watched a bunch of these interviews, and they're great. And so I just feel very honored that you asked me to do this. So thank you.
Oh, you're welcome. Thanks for coming.
Yeah.
So so why don't we start out by tell us a little bit about the trajectory of your nursing career, like how you became a nurse, and then how you got involved in psychedelics.
Sure. So I think I have a little bit of an unusual trajectory. I wasn't one of those born nurses. I never in my life ever thought I would be a nurse. I never had any interest in nursing. I never had any interest in healthcare or helping people in any way. I am a survivor of pretty severe childhood emotional neglect. And as a result of that, I spent my teenage years and most of my young adulthood into my 30s just being kind of lost. Never picking a career. I did get a Bachelor of Fine Arts degree in my early 20s, but I never did anything with it. And I got a job as a bartender in a dive bar in the East Village of Manhattan. And that was my life. I bartended up until my mid-30s for cash tips.
Right.
And that was my life. I never thought it would really be anything else besides that. I was very depressed, and I did a lot of self-medicating and self-destructive behavior.
Mm-hmm.
And then in my mid-30s, I had what I like to call a disruptive awakening. I've had many. This was the first one, where I was like, what am I doing?
Mm-hmm.
First of all, I need health insurance, and I need a steady paycheck. And I was craving stability, which I had never had.
Mm-hmm.
So I did a little bit of research, and I discovered that with my bachelor's degree, I could get a nursing degree in 2 years.
Mm-hmm.
Like 8 months of prereqs and then 15 months or so of nursing classes.
Right. And
then I also discovered that the starting salary for nurses at that time was, I think, about $70,000 after only 2 years of school, which to me was
amazing. Right.
Tips in a dive bar for 2 years, just an astronomical amount of money. And so that's why I went to nursing school, for the money and for the health insurance.
Mm-hmm.
And however, looking back on it now, I realize that that wasn't really the reason. I discovered as I went along in my career that I'm a healer. And it was just dormant, and it was latent, and I never realized it. And it took me a while, obviously, for it to come out. And I think my subconscious pushed me into nursing.
Mm-hmm.
I know that sounds a little, hokey or whatever, but I really believe that's what happened. Because there were other things I've done, but something, even though it was subconscious, led me into nursing. Now what happened was when I was in nursing school, I discovered, to my horror, that I hated anything to do with medicine. Like, I just hated it. I wanted nothing to do with it. I didn't have a science mind. I couldn't get a good grasp on physiology. And I have a memory of reading the chapter in the textbook on, what was it? Fluid and electrolyte balances.
Mm-hmm.
And like that, the sodium proton pump.
Yeah.
And the osmolality, and brain just smoking. And I could not understand it. And I was like, what am I doing? And I was nervous that I made a mistake.
Mm-hmm.
However, I loved my psych rotation.
Mm.
When we started doing clinicals, I felt weirdly at home on the psych unit.
Mm-hmm.
I felt unbelievably comfortable on the psych unit. My classmates were scared.
Mm-hmm.
Classmates were not interested in psych. They hated being there, and I just loved it. And I was fascinated by psychosis, but I really loved the patients who had depression and substance use disorders and trauma. I felt at home with them. I felt like I was one of them, and I wanted to help them. Like, I really sincerely, badly wanted to help them.
Mm-hmm.
And I had another one of these awakenings where I said to myself, I belong in psychiatry. This is it. This is what I was meant to do.
Right. So then you became a psych nurse after you graduated?
My very first job after graduation was on an inpatient psych unit, acute inpatient psych unit. And that's where I stayed there for 17 years.
Right.
So that was my entree into nursing, and I've never done any other kind of nursing.
So,
yeah.
Well, that's great. In your bio, you mentioned that so while you were on that psych unit, you started doing ketamine there?
Mm-hmm. So this is an amazing moment of synchronicity in my life. I had been on antidepressants and other psychotropic medication pretty much my whole life since I was a teenager. And around 2019, I had one of these disruptive awakenings where I was like, I don't want to be on meds anymore. I'm not getting any better. They're masking my symptoms. I want to do some true healing. And so I just made this decision to wean myself off all of my meds, which I did in early 2019.
Mm-hmm.
And right as I was doing that, I started to hear about psychedelic therapy. Nothing dramatic, just little pieces here and there, an article here,
Right.
someone talking about it there. I read an article in the New Yorker about ayahuasca that was happening in Brooklyn, and I was like, "What is this?" And just little pieces were coming into my mind, and I started to think about it.
Mm-hmm.
As I didn't want to be just flowing in the wind with no psych meds and no therapy, because I had stopped therapy at that point, and just nothing. Like, I knew I needed something. So I was searching for some kind of therapy.
Mm-hmm.
So a seed was planted in me to maybe look into psychedelics. Right at that moment, I think maybe it was even the next day after I read that article about ayahuasca, the unit director came to me at work and said, "Oh, Amanda, we're going to start a ketamine infusion service.
Mm-hmm.
Running once for our inpatients. We would like you to be the charge nurse for that service. What do you think?" So I said, yes,
Sure.
I want to do that. Yeah. And so everything just sort of came together at that time. And so I started, researching it, seeing what I had to do to get the service going. I designed like the workflow for the nurses and worked with the pharmacy and the management and everything to get this service. I mean, it was brand new. We had never done anything like that before on the site. And then they paid for me to go to a ketamine workshop.
Okay, right.
And so it happened to be at Horizons, which obviously I had never heard of. And so I went to this workshop, which was given by Dr. Shannon.
Oh, Scott Shannon.
Scott Shannon, who I know you did.
From Prati, yeah.
You did one of these interviews with him, and he was amazing. But I walked into Horizons.
Horizons is a longstanding psychedelic research conference in New York City. So, yeah. Okay, so you went to the workshop and Scott Shannon.
Yeah, I walked into the site, to the venue, and I didn't know anything about it. I didn't even know it was a psychedelic conference. All I knew was that there was a ketamine workshop going on in this building. Because my job bought the tickets and just said, this is where you go. And I walked in and there were tables set up with, all these books and pamphlets about psychedelics, about LSD and DMT and MDMA. And there was like a menu on the wall of like all the lectures and workshops that were going on. And I was like, what is happening?
And your work sent you there, right?
Yes.
Nursing job, right? Your hospital, yes.
It was amazing.
Amazing. This was 2019? Yeah.
2019, yeah.
Right.
And so I went to the workshop, which was absolutely fascinating, and I learned so much. And I just walked out of that place with a new passion. I was sold. I was like, it took me a long time. It took years of bartending, years of toiling on a inpatient psych unit in the medical system, the hospital system, before I found what I was meant to do. That's what it felt like when I walked out of that place.
Yeah.
Yeah.
Okay. So then how did it go? So then you helped set up the ketamine. So you're giving ketamine to these inpatient psychiatric unit. Yeah.
It was only inpatients. They were all patients from our psych unit, obviously. And they were all, so depressed that they couldn't function. And that's why they were admitted. Or suicidal. And some of them had actually, were there for actual suicide attempts.
Right.
And so we started slow. My first day doing it, we had one patient. And it was amazing. I mean, I watched patients get better. It was, very much the medical model. We gave 0.5 milligrams per kilogram and never diverted.
Right. Yeah.
Never went up in dose. That was it the whole time. The people that were running the service did not believe in the spiritual component. They weren't against it, but they didn't believe it was necessary to be facilitated. And so it was in a very clinical setting. There were fluorescent lights. There were people coming in and out of the room. The phone was ringing. The pump was beeping. Right. And, it wasn't the ideal setting. There was no music. There was no eye mask. So it was challenging.
Right. And people still got better, right?
They still had the neuroplasticity.
Right.
And the one good thing was that the policy was that a psychiatrist had to be there. However, they didn't have to actually be at bedside. So the psychiatrist would sit in there was like a little room next door right there, and they would do their work on the computer. But my job was to sit next to them.
Oh, great.
In arms.
The whole time. Yeah.
The whole time.
Oh, that's wonderful. Because some of these models, they just leave patients alone in a room.
Yeah.
Yeah.
Yep. So because of that, I got a lot of experience doing therapeutic interaction with these patients while they were on ketamine. Yeah. Because the doses were quite low. Because, in higher doses, you get to the point where you can't talk. Usually that's the case. Right. But because the doses were low, a lot of the patients were still verbal. So I did basically what was unofficial ketamine psychotherapy with these patients. Very unofficial. I had no training, so I don't want to say I was doing therapy, but I was.
But you were, yeah.
Whatever they want to talk about, I was following their lead. I was just remaining open and empathetic and encouraging and letting them know they were safe. You know, I had the instinct to do all the right things. I didn't try to lead them anywhere. I was just like a calm presence for them. And I think that really helped them. And I think if it had been a nurse who had been sitting there who didn't know anything about ketamine, and for them it was a job hanging a bag of fluid,
right?
You know, like
and then just sitting there, right, not even paying attention,
just looking at their phone and doing their nails. You know, I think the patients might have had a different experience,
right?
So I like to believe that me being there was helpful, even though it was the medical model. So I did see patients get better, and I did see, you know, they didn't all get better. There were some that didn't get better, but the ones that did get better was very rewarding. You know, and they would have emotional breakthroughs, because ketamine can make you very emotional. That's one of the things it can do. I would have patients that would start sobbing during it, and it, you know, it was quite beautiful. And and then they would feel better after. Right. So maybe these are people that were not able to cry with their therapists.
They couldn't access their emotions. Too many layers of defense or something. Yeah. And your calm, safe presence really helped facilitate that as well. Yeah. And
you know, and the ketamine. I mean, the ketamine
it's a tool for sure.
Yeah. So, there was a lot of positive things happening despite the pitfalls of the medical model. I like to try to take the positive aspects from it.
Yeah. I mean, a lot of research studies are still in the medical model. With, MDMA, and people are getting better as well. Yeah. So that was 2019 that started, and then we had this pandemic thing happened. Did you?
Yeah, that was rough.
You keep able to give ketamine during the pandemic, or?
I mean, it's a whole long story. I was working at Weill Cornell, which is in Manhattan, and New York Presbyterian is a gigantic hospital conglomerate, and they have campuses all over the New York area, including standalone psychiatric hospital. It's upstate a little bit in Westchester. It's about an hour north of the city. And so during COVID, what happened was they decided there was such an overflow of patients. There were patients in all of the hallways.
COVID patients or?
COVID patients. They decided they needed the psych unit, which was quite large, for COVID patients. They turned it into a COVID unit with ventilators. And they basically, they literally picked up the entire psych department and just the Westchester campus, which was a standalone psych facility. So we all had to start commuting. I mean, for some people it wasn't so bad because they lived closer to there anyway, but I live in downtown Manhattan. So for me, it was like a 2-hour commute each way.
Wow. Yeah.
But I did it, you know, it was COVID. You do what you have to do. So when I got there, they didn't have the ketamine going yet. So I helped them set it up. And then we started doing it there.
Yeah, great.
Yeah.
So, and then now you're a psychiatric nurse practitioner. So when did that happen? Yeah.
So everything I've been talking about was when I was an RN.
RN, right? So are listening, you can be an RN and do this.
Yeah.
Right. But you decided you wanted a nurse practitioner degree. So then how'd that come about?
About early 2020, I've been working with ketamine for about a year, probably, or a little less than a year. And I had decided it was my passion and that I wanted it to be my career. And even though I was working with ketamine, I was like double duty also on the psych unit. And I just was done with it. I didn't want anything to do with that anymore. And I really just wanted to work with ketamine.
Okay.
So I started to look around to see what kind of RN ketamine jobs were out there. And there are not a lot. RNs. And the ones that were out there were in ketamine clinics that were the medical model. And your job was to insert IVs and get the bag ready and hang the bag and take blood pressure. Story.
But not sit with the patients or do more.
And like about a 50% pay cut for me.
Right, compared to a hospital, right? Going to a clinic.
And I didn't want to do that. I wanted to work with ketamine, but not in that way. And then I looked into other things. I mean, I know you can become like a nurse coach, and maybe study therapy and do some ketamine integration. Like I looked at that route also. I don't know why I didn't want to do that. It just wasn't for me. I wanted to be. I really like being hands-on and working. Like I didn't want to do all telehealth. I wanted to be hands-on and do and work with the actual. Like I wanted to touch the medicine. You know what I mean?
Right.
So I was like, I got to become a psych MP. That's the only thing I could. I didn't want to, but
right. Just go learn electrolytes and yes.
I didn't want to go back to school. I don't like school. But I bit the bullet and I said to myself, if I really want to work with ketamine in the way that I want to work with it,
I need this degree.
I have to become a psych MP. That's the only thing I can do.
So you did.
So I did it. Yep.
You did. And now you're working at Stella Center, right?
Yep. I graduated in May of 23.
Okay.
And it took me 8 months to find a ketamine job. So I finally got a ketamine job in January, this past January. Okay. So I've only been working as a psych MP for 5 months. Yeah.
How's it going?
It's amazing. I love it. I love my job. I'm so happy there.
Right. Can you describe some of what do you do in your role there?
Well, it's a pretty much traditional ketamine clinic, but I am able to facilitate psychedelic experiences. It's set up for psychedelic journeys. We have ketamine. We have 4 ketamine rooms that are very calmly decorated with dim lighting and like cloud wallpaper, and the chairs that go all the way back, the zero gravity chairs. It's only IV.
Okay.
And we have amazing playlists with noise canceling headphones and the eye masks, and we also utilize a microphone so that when the patient has the headphones on with the music playing, I can talk to them. They can also hear me through the microphone into their headphones.
Oh, nice.
Yeah. So that's a really nice touch.
They don't have to stop the music. Not so jarring.
Yeah, we don't sit in the room with them, but I stay with them for all during takeoff and as they're emerging. And we also have cameras, and we can all of the patients are on camera in the office, so we can see
if they're having an issue. And they have a call light as well, probably.
And a call light, of course.
Yeah.
Well, it's a call bell. It goes ding dong. Very loud, so we know.
Right.
Yeah. And it's actually Stella took over from Field Trip. If anyone knows about Field Trip, it was a ketamine business that went bankrupt. But so Stella bought all their spaces. So it's not the same company, but it's the physical space.
The same, right?
Yeah.
Design, yeah.
Which is why it's so beautifully decorated. I mean, they did an amazing job of decorating the space.
Right. They spent a lot of money and then went bankrupt, but they made a nice space.
It seems like it. Yeah.
Yeah. Well, that's great. It's nice to hear that you achieved your dream. Your goal was to be able to do ketamine.
Yeah.
You went back to school. You did it. You graduated. You found the job, and now you're doing it, and you're enjoying it. Yeah.
Yeah. I mean, every job has its drawbacks.
Of course, right.
But it's. I just feel very grateful that I'm able to administer ketamine to patients that are suffering in a beautiful space and in a way that facilitates spirituality and consciousness raising. And it's ideal in that way.
That's great.
Yeah.
So yeah, so do you think nurses bring a different perspective to psychedelics? I don't know if you've worked with other doctors, other people providing ketamine, or just in general. What do you think? How the nurses are, special?
Yeah, I definitely think nurses are special. It's difficult to generalize, at all about anybody, because there are some psychiatrists that are like, psychedelics is bullshit. Oh, wait, I have to say that.
It's
Sorry.
okay. It's all right. Yes.
And then there's some psychiatrists that are all in. You know what I mean? So it's hard to generalize, but I do think that nurses are people who choose to become nurses have, I think, towards being soothing and compassionate and empathetic, even if they don't realize it, like as was the case with me. Even if you don't realize it, you make the decision. Even if you decide to become a nurse for the money, I still think that's in you somewhere.
Right, or at least if you're going to remain in nursing. People become nurses and they don't last very long because
that too.
It's not for them. But yeah, anyone who kind of remains in nursing, there's something special about,
It's like an inner healer. And they have that inner healer, and not everyone that works in healthcare has that. There's people who work in healthcare that are brilliant in other ways and amazing in other ways, and and heal people in other ways. But there's something about nurses that I don't, and also they're hands-on nurses.
Great. Nurses are trained to touch people. Right?
Yeah, they actually touch people.
And to jump in and touch people when they,
Yeah, and that's significant as well. And there's something tangible. There's a tangibility about nurses. They're down to earth. They tend to be less analytical, maybe, in terms of, when they speak to patients. It's more like a loving touch and an empathetic understanding, as opposed to, well, let's figure this out. Like, let's dig into your childhood. Some nurses do that, but just in general, there seems to be like an innate down to earthness about nurses.
Okay. Yeah, I agree with that.
Yeah. Right. And then if you stay in nursing, that's another thing. Like, why do you stay? It's not an easy job. There's a reason why people stay, like you said. They get something out of touching people and being a nurse a jack of all trades. I mean, can I quote your presentation?
Oh, the Swiss Army knife.
Yes. Wendy did this amazing presentation called "Nurses Are the Swiss Army Knives of Healthcare," right? Or of psychedelics.
But yeah.
100%.
Right.
We've been around the block, and we understand every aspect of healthcare and people.
Right. Yeah.
And we're like the front lines.
Right. We are. Yeah.
We're with the people.
That's great. Let's see. So, how do you envision nurses in this psychedelic future that's coming? Psychedelic therapy we have ketamine now, MDMA, psilocybin are coming down the pike, other maybe DMT, LSD. There's a lot of, potential coming here that's going to be legal for medical or other use, depending on what state you're in. How do you envision nurses getting involved with that? Or
I think there's a lot of room for nurses. I mean, come on in. I think especially MDMA and psilocybin, we need people. We need bodies. So I think nurses might be able to fill that role, even RN, especially RNs.
Right. We were talking about when you were doing your ketamine work, right? You were sitting with those patients, you were holding space, you were having therapeutic communication, which nurses are trained in.
Right.
We are trained in how to communicate with patients and how to hold space.
Yeah.
If you're not formally trained as a therapist, you're still trained in therapeutic communication, right?
Yeah.
They could sit, right, even without extra training.
Yeah.
Yeah.
Absolutely. And there's a huge problem with the cost of MDMA and psilocybin. Do they want to pay two psychiatrists to sit for 8 hours.
Right. Probably not. Yeah.
Or a psychiatrist and a therapist. I mean, can be thousands and thousands, as we all know.
Mm-hmm.
Dollars. So maybe a psychiatrist and a couple of nurses, maybe a therapist and a couple of nurses. I see that as a huge part of the future.
Right. Yeah. Get a few Swiss Army knives in there to get it done.
And also nurses, even if you're not trained with that, you pick it up on the job.
Mm-hmm.
You talk to so many patients during the course of your shift,
especially
if you work in a hospital. I mean, you just learn how to talk to people.
Right. Yeah.
Yeah, by osmosis.
And then, and if you do, so you chose to get an advanced degree, but do you think nurses need to get advanced degrees to do this work?
I don't think so. I mean, it depends on what you want to do. If you want to be if you want to be a prescriber, if you want to be like more, I call myself the matriarch of my clinic because it's me and a lot of nurses mostly.
Nurses, okay, right.
So I'm not the boss, I'm the matriarch. So if you want to do that, if that's what you're interested in, you should probably get an advanced degree. But if you just want to be involved somehow,
there's opportunities.
Yeah, I think there'll be plenty of opportunities. And I know there's a lot of talk right now in Oregon and about who should be legally able to administer psychedelics, and that's a big topic right now, right?
Right.
Do letters after your name really mean anything?
Right.
I'm not so sure. I mean, I know the training is important, obviously. But to be honest, I graduated with some people that had PMHNP after their name that I would not want to be anywhere near me when I was doing psychedelics.
Right.
It's more of the person.
Yeah. There's several organizations working right now trying to figure out how do we license in Colorado, Oregon, the BPMT, which is the Board of Psychedelic Medicine Practitioners, which Scott Shannon, who you trained ketamine, has started. Now there's other people running it, but they're trying to figure out, who do we allow?
Yeah.
To do this, how do we have some sort of a certification test or some kind of criteria education? But as you know, just because you can pass a test doesn't mean you know all the things, right? Or your classmates who jumped through all the hoops and they got their degree. But so it's a
huge issue, isn't it? It's like, what are we going to do?
How do we declare somebody's okay to do this, right? Apprenticeships, and then, if these things are approved, if MDMA is approved, how many thousands of psychedelic therapists we're going to need, like, immediately?
Yes. So. It seems like there's a lot of those. I mean, I think we need more, but.
Right. We're going to need people to work.
Yeah. And also just because you work in psychedelics doesn't mean you understand it fully. There was someone that I worked with in the hospital when we were doing ketamine that, believed that if this patient started to disassociate or have a difficult experience or started crying, that was an indication to stop the infusion. And this was someone who had studied ketamine and all the science behind it. It was a ketamine provider.
Right, he thought that,
and so I had to teach this person that just because a patient is crying doesn't mean you need to stop the infusion. It's not a bad side effect. It's actually good.
Right. Maybe they need to cry, right?
So stuff like that is happening in the ketamine world. Like, people are working there that don't really understand.
And there's so many different ways, to work with it. And because it's already legal, anyone can start, right?
Yeah, exactly. And when MDMA and psilocybin become legal, that might be the same.
It might. It's unclear yet if there's going to be a REMS along with MDMA, government regulation about whether you have to have a therapist, or who can be the therapist, or right?
Yeah.
We don't know. Can you use it off label?
To be determined.
It's right. It's coming. So when you were doing the IV ketamine in the hospital, how long would you run the infusions for? Was it a set amount of time, or was it titrated to how the patient?
It was always 45 minutes.
Always 45 minutes, and always at 0.5 milligrams per kilogram. Yeah.
Correct.
And how does that compare? What are you doing at Stella?
At Stella, I have freedom.
Mm-hmm.
I usually I dose them weight-based for their first session.
Mm-hmm.
And then titrate up from there up until they get to a plateau where they love,
Mm-hmm.
where they're getting benefit. If they want to go more, I don't really have, like, within reason, I don't have a huge upper limit. I can go to really high doses if I want. And I also can turn up the rate of the pump if they want like a more intense journey.
Mm-hmm.
Or I can slow it down if they want it to last a little longer and be a little softer. So I have total leeway in.
Right. Is there a set total amount you're using, or an amount of time, or how does your?
It's generally 45 minutes, unless I slow down or increase the rate, but I don't do it by that much.
Mm-hmm.
So I guess the longest would be about an hour.
Okay. Yeah.
And then we have the time and the space to let the patients chill out for a while. We don't rush them out of the room.
Right.
So even after the infusion is complete and the pump is turned off, I let them stay for as long as they want.
Okay.
Just processing, luxuriating, coming back. If they want to talk,
you'll do a little therapy.
I knock on the door, and I come in the room, and I say, do you want to process anything? And if they do, I sit down and we talk. Sometimes they say no. Sometimes they're completely inarticulate, and I say it's fine.
Right.
I'll see you as you go out. I'll say goodbye. So it's completely patient dependent.
And then, are they allowed to go home by themselves, or do they have to have someone pick them up, or how are you?
They either have to have someone pick them up, or they have to go. We have to see them call an Uber.
Okay.
Yeah.
So.
Yeah.
Yeah. It's always interesting to hear how different clinics do things.
Yeah.
Because there is no one set way. So. Yeah.
Right. Yeah. We don't want them getting on the subway.
Right. Getting lost.
I don't think it's dangerous, but it would take away, I think, from the.
If they got a little confused, or interacting with other people, when they're so open.
Right. Exactly.
That makes sense. So yeah, maybe do you have any stories about how, if you ever talked to other nurses or just other people about that you're working with psychedelics? What kind of responses do you get, and how do you explain that? In your.
Yeah. Luckily, my experience has been, for example, when I was at the hospital working on the psych unit and we were on the nursing station, if I brought it up and started talking about it, the nurses that were interested would ask me lots of questions. Nurses that were completely silent and looking away and doing their charting were judgmental.
Yeah.
They just didn't say anything. But I could sense that they were. And I've had a few non-nurse people, acquaintances that think it's, hippie woo-woo. They've expressed that, or they've said, I had one a friend who said, oh, my friend did ayahuasca and she came back exactly the same person and it didn't help. And, why go through all that? And I heard you vomit and that's horrible. And why would you put yourself through that? And then, yeah. Oh, here's a good story. I was talking to a psych practitioner at my hospital job. And I was telling her, and it was when I was in school, and I was telling her that I wanted to work with ketamine. And she said, quote, "Doesn't that make you high?" And I said, well, that's not the purpose of it, but you do go into an altered state.
Right.
Yes. And she said, well, she's like, that's not ethical. We shouldn't be getting patients high. that's not right. And I said, well, look at the research. I'm going to email you some research. There's, I started to explain to her all about the neuroplasticity and, all the things that you tell people who are doubtful about ketamine. The whole brain chemistry speech I gave to her. And she said, and I said, there's evidence. And she said, oh, okay. She goes, well, then if there's evidence that it helps depression in that way, maybe why don't we give naltrexone with the ketamine so they don't get high? So they get the neurochemical benefits, but they don't. And I was like, what kind of horrible person are you?
Right. Did she withhold pain medicine as well? Because someone might get high as well as have their pain be treated.
She might be one of those nurses who would do that. Yeah. I don't know. Yeah. But generally, generally people are quite supportive, and if they don't know anything about it, they're very curious and they ask a lot of questions. Or they say a lot of, oh, I have my dad, or and it helped more.
Right, and it's becoming more common now. People are like, oh, well, my uncle tried ketamine and for his depression, and it helped. There's enough of these clinics, or the Michael Pollan effect. Now people have learned about psychedelics are on the mainstream news.
100%. A lot of people have mentioned that book. Another thing that happens when you let it be known that you're interested or working in psychedelics is that you start getting lots of texts from friends of friends and acquaintances looking for psychedelics.
Right. Like,
or
no,
for advice.
Yeah. So let's see. What else should be? So what kind of advocacy roles do you see nurses doing? You think nurses have the power to
of course, nurses are
laws or things, or
nurses are very knowledgeable. They're a lot of them are trained to be educators as well, and they're going back to that same point of just the exposure that we have to all, especially ones that work in the hospital, where a little bit about everything, and you pick up ways of communicating, and you can articulate your thoughts, which I'm not doing very well right now. But if you go in front of a committee, you have so much different knowledge, and not only that, you're respected because nurses are very respected. Isn't there that statistic that we're the most
trusted profession? And then there was the Berkeley psychedelic, that new training institute, or Berkeley, they did a survey about who would you want to teach you about psychedelics, or who would you trust to educate you, and nurses were at the top.
Really?
Yeah,
that's awesome. I love that.
Doctors were up there too, but nurses were at the top of who do you want to learn about psychedelics from?
Yeah,
that's cool.
So that tracks in terms of advocacy and policy, because politicians will listen to us and the committees will listen to us.
Right.
We should be in there for sure.
Right. It's like so last month I had interviewed Wendy Johnson in Utah, and so she's a psych NP, and she testified in front of the Utah legislature when they passed their bill for psychedelic therapy. Yeah, so
amazing. Oh, they passed the bill?
They did. Utah, yes, the state of Utah. Right, and it was a psych NP who was testifying. Yes, so that's so. For those of you who missed it, it's last month's interview. Yeah, we had a.
Who would have thought Utah?
Right, but at the same time, there's libertarian, right? Kind of, you have a right to,
right.
Freedom to explore and autonomy.
Yep.
Okay, so we got one more question, and then we'll take some questions from the audience. We kind of like to have our question. If you could go back and give your younger self a little bit of advice, what would you tell your younger self?
Okay. Oh wow. Floss your teeth is number one.
Okay.
Because if you floss your teeth, it will save you thousands of dollars in dental bills.
Okay.
And what else? just don't worry so much.
Mm-hmm.
Just don't worry so much, especially when you're young. Life gets so much more stressful when you get older, and you have so much more responsibility. Even if you try hard not to, you just automatically do.
Mm-hmm. You don't sweat the small stuff so much.
Yeah. I mean, the anxiety, just let that go.
Mm-hmm. All right, and floss your teeth.
It'll be harder to let go as you age.
Mm-hmm. It's kind of as sort of as a practice to learn how to let go. Well, great. All right, so I think we'll take a few questions from the audience here. Let's see. I don't know if Andrew is backstage. We'll see what we got. Here's one. This one's a little, oops, there we go. This is from Heather Honstein, who actually interviewed about a year or two ago. So, in your practice, how many ketamine sessions do folks usually receive? Is it a month or two of treatments, or are some folks regular clients who come indefinitely as needed? And then how are abuse risks mitigated?
Patients come in for 6 sessions.
Okay.
6 ketamine sessions. That's considered a course of treatment, and that's usually over either 3 times a week for 2 weeks or twice a week for 3 weeks, depending on their schedule.
Okay.
That's what we push. Every once in a while, there's somebody who has a specific circumstance with work or with traveling or something where they can't quite do that. And so we have a little bit of leeway. We're not totally strict with that. We can do maybe 1 week, maybe 2 sessions, the next week 1, and then the next week 3. We work with them. And that's usually it, unless they come for boosters, a maintenance treatment, in which case they come, maybe they wait a couple months, then they come for 1 or 2 treatments, either 1 a week for 2 weeks or twice in 1 week. And we have some patients that do that every couple months.
Okay, come in for a little tune-up.
Yeah, a little tune-up. I've only been there for 5 months, but I don't think since they've been open, they've had someone who's repeated a 6-week.
The full.
I don't think that's common.
Mm-hmm.
Maybe it's more common after a year or 2 or a couple of years. But the common thing is 6 treatments, and then either we never see them again or they come in for maintenance.
Okay.
Risk mitigation is tough. They have a telehealth intake, obviously, where they get their entire history, including substance use history.
Mm-hmm.
And they're carefully screened before we let them start. But however, sometimes people can slip through because not everyone is honest in the intakes. There's really no way for us to know if they're being honest. But the clinicians can usually tell when someone's just there to get high. Mm-hmm. So there's a different flavor and a different quality to it. And it's happened to me once where I suggested to leadership, maybe we should talk to this patient about not continuing. Mm-hmm. I didn't think they were depressed. They didn't seem to be depressed or anxious or anything, or have any kind of diagnosis, or a thrill seeker.
Right.
So, I just had to go to leadership and have like a conference with them.
Right.
So we had a whole meeting about that, but that only happened once. That's pretty rare.
Right. Because you're only doing IV there. You're not doing sublingual. No one gets any take-home ketamine, which can get, more of an issue that way. And
then we do have patients who admit to drinking, and we just ask them to, abstain from drinking for a week
before
treatment, and definitely, absolutely the night before, the day of. And hopefully they comply. We haven't had any trouble.
Any urine, like a urine screen? No.
I trust them.
Yeah. Okay. All right. This question from Rach M. Do you know how patients are being chosen to get ketamine versus ECT? You share how you counsel your patients on the experience, right? I think that the managing expectations, right? People hear that psychedelics going to do all this amazing things to them. How do you set the container, right, without planting expectations that this is what's going to happen.
Mm-hmm. Well, I'll answer the first part of her question because, well, I failed to say that I also, at my hospital job, I also worked with ECT before I started the ketamine, and so I have some experience with that too. And the difference between ECT patients and ketamine patients is that ECT patients are much more severely ill.
Okay.
They are, we call it psychotic depression. They are so depressed that they are in a psychotic state, usually, or so depressed that they become catatonic. We had catatonic patients that did full medical workups and nothing. There was no physiological indication for their catatonia, and it was depression. We also treated severely manic patients with ECT, and it really helps with mania. So it's almost the opposite of ketamine patients. Contraindicated psychosis and mania are contraindicated for ketamine.
Okay.
So that was the differentiation.
Distinction, yeah.
Yeah.
How about the second part? How do you counsel them on what the experience will be like without and managing their expectations?
That is really tough. That's like one of the hardest parts of my job. And one of the biggest causes of that is the media, honestly.
Right.
The media is really building up psychedelics and ketamine to be a cure, a magic cure. And these patients come in believing that. And there's that headline going around like, one night of psilocybin is like 10 years of therapy. That's just the worst thing they could write. And so these people come in thinking they're going to have one infusion and feel better.
Right, magic bullet.
So I have to explain. It's a lot of explanation about how it's an up and down course. You might feel worse before you feel better. You might not feel better. There's such non-responders. The whole gamut. I have to explain the whole gamut of possibilities. And I also try to say, if you get more depressed and you feel a dip and you feel a contraction, that doesn't mean it's not working. That could be a positive thing. I try to remain encouraging in that way. And it could also be healing can be very difficult. I myself have been a ketamine infusion patient. And for me, when I was done with my 6 infusions, I was very dysregulated for a couple of months after, because I had such incredible defense mechanisms from my trauma that were all softened and melted by the ketamine. And I was not used to navigating through the world in that way. So I walked out of the ketamine clinic into the world and into my job and into life like an open wound.
Right.
And it was very hard, and I really struggled. So that can happen too. And that's pretty common. But I knew I had enough psychedelic literacy to know that was part of
what's happening, right?
And so I was okay with it. But somebody who might not know that might be like, "Oh my God, it made me worse." What is this? It made me worse, and they might get really scared. Right.
Do you feel that psychedelic practitioners should have their own psychedelic experiences?
I personally think they should. I don't want to say, they have to. I'm not like that kind of person. Like, you have to do this. It's up to them.
Is it offered to the employees at Stella? Like, for your training or just,
Yep. It's offered. I haven't done it there because I feel weird doing it at work.
Right.
It's very vulnerable, but it is offered, which is great. And I think it would really help people that are involved in psychedelics in any way to do them.
To have a little experience, yeah. All right. Can an RN do integration sessions without getting a master's or NP degree?
Not formally, no. You have to be a therapist.
Right, or a psych NP could, right, we can go for therapy.
Yeah, you have to be a therapist or psychiatrist or a psych NP. A therapist could be a clinical social worker or a psychotherapist. but just a straight ahead RN, you can't. But that doesn't mean you can't be a hold space and do partake in therapeutic interaction.
Right. I do think, some people with the nurse coaching now.
Nurse coaching too, yeah.
Are actually doing a little bit of like that integration.
Right.
Stuff.
So do they become nurse coaches and then also take like an integration course?
I
think, yeah.
Yeah, so maybe you don't have to have a master's or nurse practitioner, but some sort of extra training would be helpful. Yeah. Okay. Anymore. Oh, here we go. From Jennifer. Thank you so much, Amanda. I relate to so much of what you shared here. I worked in inpatient and outpatient psych, burnt out and left the field. Recently completed the CIS CPTR program. Had a recent personal experience with ketamine. Any advice for someone re-entering the nursing field as a BSN? She's in LA.
Oh, that's a hard question. I mean, I'm not sure I understand what she wants. She wants to know, like, she's sick of working in psychiatry.
She got burnt out in psychiatry and left, right?
Yeah.
And I think she trained in psychedelics in California, the psychedelic certificate. And now she's going to re-enter the workforce as a BSN.
Maybe try to get a job in a ketamine clinic. I mean, I know I was sort of bad-mouthing it earlier, but at least you can be around ketamine. And you can learn about ketamine.
Right. And depending on the clinic, nurses are more involved than others. Yeah.
Yeah. Or try to find a nursing job in like a small, not in a hospital, like in a private practice or mental health practice. I don't know if they do that I don't know if psych nurses do that, but
right.
It's hard.
Having the new knowledge and perspective, right? Having had a break, you got burnt out, you left, you can kind of re-enter the medical field with sort of fresh eyes.
Yeah.
And not take on some of the baggage that the medical model has, and you can still maintain your identity while being in these spaces.
Yeah. I would look for a job in a ketamine clinic, honestly. Yeah. There's that place. What's that website that sends out psychedelic jobs?
I don't know.
Well, there is. I think it might be Psychedelic Alpha or something.
Oh, right. Yeah.
If you sign up to their mailing list, they send you like every week. There's like a list of people seeking jobs in psychedelics, and once in a while seeking employees, and once in a while a nurse job thrown in there.
Very cool.
Yeah.
So check that out. All right. This is from Darlene. She's based in New York. Did a psilocybin assisted therapy training in Oregon last year. Very much trauma informed, trauma focused. What is your thinking about doing this work in a trauma informed way?
100%.
Yep. Everything's trauma informed if you're doing it well, I think.
Yes, 100% trauma. Like, there are so many traumatized people that turn to psychedelics. And it is so important to know about trauma and to understand it and to have training in it and to empathize with it. And yeah, I applaud you for doing that. That's very important, especially if you want to get into psychedelics. And I even think, in the underground world, this is a little bit of an issue because I see we only have a minute, but
we can go a few minutes over.
Okay. I think that sometimes what happens in the underground world is that, depending on the group, if you go to like a psychedelic group, you get a lot of what I call parachute jumpers. And they're people that are generally very healthy, but they want to try psychedelics because they've heard about it as like an adventure. So you get those people. And then you get someone who is desperate and is like suicidally depressed and wants to try psychedelic therapy to help their depression. And they're sitting next to these other people. And then there's a facilitator who's not trained in trauma. And I just think that doesn't always work.
Right.
I think that one person who's suicidally depressed among all these generally healthy people, I mean, not everyone's totally healthy, but, more healthy, that person can have such a hard time, and there's a lot of shame can come up. Rainbows and giggling or seeing their dead grandma come and give them a hug or whatever. And the other person is, curled in a fetal position and grieving and crying and
Right.
their traumas being surfacing. Then what happens in the integration circle? It's like you get to that person and everyone's talking about their rainbows. And I don't know, that person really needs to be held in a special way. And so if these facilitators can recognize that and understand that and recognize a person because that person might not speak up.
Right.
Because of shame. There's so much shame in our culture. So a trauma-informed facilitator is so crucial, in my opinion, with psychedelics, even in the underground scene, to recognize someone going through that.
Especially with the kind of loss of control with ketamine, or the disassociative part of ketamine, right? And yeah, if you have trauma history, can you feel safe in your body or trust what's going on?
Yeah.
So yeah. Well, great. It's been great to hear more about your journey and what you've accomplished and where you're headed. And it's inspiring, hopefully, for a lot of our audience. Yeah. Do you have any?
You can do it.
You can do it, right? Do you have any last thoughts or anything you want to say to our psychedelic nursing audience here?
No, I have gratitude for this community, and I'm in favor of anyone who's interested in this community and in psychedelics. It's a beautiful place to be. A lot of promise in this messed up world. This is one beacon of hope and light, and just keep it going.
Yeah,
and that's it.
So yeah, keeping on. The nurses are gonna rise and hold up space in a trauma-informed way.
Yes.
Please, join us on Facebook or on our website. We'd love to help connect. Yeah. So thanks, everyone, and have a great night.
Bye.
And don't forget to follow us, right? Bye.